We need anything else? Okay. Hello, how are you? Good. Welcome. injury. When I met this lady she has become a definite mentor to me, a definite friend and sister to me, and I learned so much from her, and she told me she's learning from me. But I tell you what happened when we first met, we didn't like each other. Well, she didn't like me. She thought that, I'm coming from an AA perspective, and she was already where I am now. So to me, it was like it just didn't match. But anyway, check this out. So as we continue to be around each other, and she listened to me, she had her aha moments. And so I went to her office one day. They were having a meeting there, and she just really blew me away because she said I was so wrong in my snap judgment of you. And she said she was working on something in her life that day that just blew me away. And from that point on, we just have been super cool. So then right after that, I run into her again in her office, and she said, I said, how was your weekend? She said, my weekend was good. She said, I took this guy down to the west side of Chicago on California and Jackson, and let him buy some dope, and he got in the back of my car, and I tested it and let him use. I said, what? But you understand where I'm coming from. I hadn't turned the corner yet, so I didn't know about harm reduction. So harm reduction is she got the guy, able to take him safely, because he was going to go anyway. But this is when fentanyl had just really touched down and was really, really bad. So she carried around, like she does, her fentanyl test strips. So she was able to take this cat, get him, let him get what he's going to buy, and test it, and then let him use. And he used safely. But it still took me a minute to wrap my brain around that because I wasn't used to harm reduction or hearing that. So I had to not only get educated, I had to get a better understanding from her about it. And it has just blown away for me because I have people in my groups who are practicing harm reduction. And I like the way she, in layman's terms, how she explains harm reduction. Do you know when you get in your car and you put your seatbelt on, that's harm reduction? Anything that gives you a titrate away from harm is harm reduction. You know, I didn't understand that at first. So she's just super cool. We work so well together. We meet up once a month and go and have catfish and grits and whatever other stuff we have at the Southern. And she's just super cool people, and she has a plethora of knowledge in this arena. And so I'm grateful to introduce my friend and sister on Friday. I call her Love Friday.
I'm like,
yeah.
It's come quite a way, thank goodness. I'm used to pacing. This is going to be a little difficult for me because I'm Italian. I walk, I talk with my hands, so bear with me. My name is Laura Fry. I am a person in long-term recovery. And what that means to me is that I ended my chaotic relationship with drugs and alcohol. It's a pleasure to be here. I am the executive director of an organization called Live for Lolly. We've been around for 13 years after the overdose death of Alex Lalaverte. And we do a lot in the community of Northern Illinois. Not only harm reduction, like Daryl was talking, peer support, education, and a lot of advocacy work. I got a note saying here, who does that? This isn't Vietnam era. Well, learned a lot in the last 10 years. Without further ado, I will move through this. Everybody here will be trained in how to recognize an overdose and how to reverse an overdose. Can I see a show of hands? Who here knows someone or of someone or heard of someone that died of an overdose? A lot of people. Okay. Second question. Who here carries naloxone on their person? know why I ask that? So many of us know of someone that had died of an overdose. Why don't we all carry naloxone? My theory is if you are a human and you happen to encounter other humans, I've reversed overdoses after Cummins Preserve on a hike. My son reversed overdoses in the parking lot of the Starbucks in Crystal Lake. You just never know. And it is very powerful to be able to come upon someone who is blue and not breathing and give a little nasal spray and bam, like that, they're back. And they have another chance. Because you know the only thing that is absolutely imperative for recovery is just one thing, a heartbeat. And without a heartbeat, nobody's able to recover. So that is my theory, why we all need to carry Narcan, and I have plenty of it here for everybody that wants it. Okay, I'm really gonna move on now, Dan. Lots of things.
I feel like all did the new naloxone training. Let me tell you something. I'm watching that, and Caucasian individuals turn blue. They get blue, you know, and all that. This beautiful chocolate skin. If I was to overdose, I don't get blue. I get ashy. I don't have blue or green eyes. So my eyes just go completely black. My look, as opposed to Laura's look, is totally different. So I wanted to make sure that a person of color is acknowledged in how they would look if they're an overdose. That's very important. Okay? That's all I have.
I got a slide on that. Because he taught me that. It never occurred to me. Okay, 254 people. That is the number of people that are going to die today from an overdose. Yesterday, tomorrow, next week. In 2020, because this is my personal belief, I don't have a scientific study on this, we saw the most amount of, and I just got a new notification yesterday from February of 20 to February of 21. There was over 96,000 people in the United States that died. Over 3,500 in the state of Illinois. We're in crisis. I always get ahead of myself. That's the number of people we lost in Illinois in 2020. Out of those 93,000 deaths, 75% had an opioid present. What we do know now is that we are finding fentanyl in everything. I test people's supply regularly. No one should have to go through that. Some objectives here. What are opioids? How do they work? How do they affect the body? How to identify an overdose? Overdose prevention and policy. And what is that stuff called naloxone? What we do know is that the majority of youth receive their substances when they first start experimenting from a friend or relative. That does not mean that Aunt Mary says, oh, here, I'll share my prescriptions with you. What that means is that we have to lock up our drugs, even if it's not something that's abusable. For example, I had a fresh prescription of antibiotics for a toe infection I got after having a pedicure. Who needs to hide antibiotics? The next day they were gone. I thought I lost them. I just went and got another one. 5 years later, my son says, Do you know what I was able to do with those antibiotics? I took that to the west side and I traded for 6 bags. Lock up your medicine, don't get the temptation. Dispose of any medication that you don't use. Most police departments and many Walgreens and CVS's have kiosks where you can bring your medication. Properly dispose of it, do not flush it. Bring it somewhere where it can be disposed of. Let's keep it out of our kids' hands. Keep going, Pam. Prescription narcotics are the 4th most commonly used substances by youth. And this might be a fact you don't know. More people die from overdose every day than gun violence, car crashes, or suicides. This is the youth study, the Illinois youth study that goes out every 2 years. I don't know how much validity I put into it because kids don't tell the truth on these kinds of things. But the last time this was done, 1 out of 8 high school seniors reported misusing opioids that did not belong to them. 80% of new heroin users started with an addiction to prescription opioids. And I think what I really want to point out is this last bullet. 15.1 million adults in 2019 needed treatment. 1.4% got it. I mean, let that sink in. Blows me away every single time I read it. In this country, in 2019, 153 million opioid prescriptions were written. The highest of any country in the world. We are the only country that uses Vicodin. No other country has that compound. Any doctor can write any amount of opioid prescriptions. However, one of the very successful medication-assisted treatments for opioid use disorders, Suboxone, doctors are limited as to how many prescriptions of Suboxone they can write. Yet they can write millions and millions of opioid prescriptions. Some of our legislative efforts, Illinois has Good Samaritan law and the naloxone law, which were passed together in 2010. Yet our overdose rates keep going up, so why? Why aren't people calling? Oftentimes, I think it's because they just don't know that the Good Samaritan law exists. Fear of engaging with law enforcement. Along with substance use comes issues with law enforcement. They might have a warrant. People feel that they might get charged. If you are using a substance with a friend and they fall out and you call 911, you will not be prosecuted for that incident. Oftentimes, people will throw someone in a cold shower or in a snowbank. Really, the only thing that will reverse a true overdose is naloxone. There is no other way. So just spread the word that Illinois has a Good Samaritan law. Spread the word that any lay person who can understand the instructions can use and administer naloxone without fear of persecution. The youngest person I ever trained was 8 years old, an 8-year-old girl. Her mother was a heroin user. It was only the 2 of them in the house. She needed to know what to do in an emergency. I think I already said that. So So in Illinois, since 2010, we have recognized naloxone as a standard tool. When you take CPR now, they talk about if you come upon someone that is unresponsive, assume opioid overdose. I am a trained ER nurse. It used to be assume cardiac arrest and begin compressions. Now the American Heart Association teaches you if you see someone down, assume opioid overdose. That should tell you what a big crisis this has become. Naloxone training is for all people, as long as you can understand how to use it and how to recognize an overdose. So what is opioid use disorder? It is continuing to use opioids despite negative consequences. Opioids tend to hijack the brain. Opioids attach to our opioid receptors. We all have them, and that is what floods our brain and our body with dopamine. Dopamine is our feel-good chemical. Each one of us get our dopamine response in different ways. You've heard of runners who talk about the jogger's high. That's what it is, it's dopamine release. Some people get a dopamine release after sex. Personally, it's meatballs. But what opioids do, they go to your brain and they attach to every opioid receptor and jam it open. So you're getting all of the dopamine that your brain produces all at once. And it's an incredible feeling. Are you gonna eyeball me if I'm running over?
Go ahead. Yeah.
Okay, good. A lot of time is spent on obtaining their medicine. This is their medicine. And a lot goes into obtaining it so that they are not sick. My son has told me that dope sickness or opioid withdrawal is the worst thing he has ever felt in his life, and my son had brain surgery. That's where his morphine addiction started. That it feels like the worst flu times 1,000, that it feels like all of your bones are shattered like glass and rubbing against each other. Nobody would want to feel like that. So that's, it hijacks the brain. And once you flood your brain with an opioid that you're misusing, our brain is a wonderful thing, but it's kind of lazy. It stops making it. It stops producing dopamine. It stops producing serotonin and melatonin. So that is why people get so sick. That's why they keep using. Who would want to walk around with no dopamine, no serotonin, and no melatonin? It's not a good existence. Do we have time to play the video?
Please.
Let's go help people customize and save Liberty Games. Okay, who's sat at my desk?
People contemplating recovery often have a lot of fear around
That's not the right video. There it is. This will give you a peek into what addiction is like without ever saying a word. When I first saw that, I sobbed. That was my son. That was my son. And I show that video to every family that I work with. There is not one person who wakes up one day and says, hey, I think I'm gonna shoot heroin. Not a soul. And in the end, you saw with our little nugget, it's dark, they're alone, they don't wanna do this. So why do people take drugs? Probably as many reasons as there are humans in the United States. To make a good feeling feel better, to make a bad feeling feel better, to mask psychological injury and trauma, because their friends are doing it, because their parents are doing it. There's so many different reasons. Personally, I started using substances at 12 because I had experienced sexual abuse within my family from the time I was 3 until I was 13. That was my reason. And exactly what Daryl said, I was able to give up the substance 40 years ago pretty easily. But man, I didn't get into recovery until about 10 years ago. Because there is a huge difference between being sober and being in recovery. Huge. Took me many years to go through that. So what are opioids? Opioids are sedative narcotics. They are used to treat pain very successfully. When I used to work in the ER though, I would go in after the doctor and I would say, do you know where that prescription works? Say someone came in with a sprained ankle and they got a prescription for Norco. Do you know where that works? Patients don't know where their medication works normally. I said, that Norco works in your brain. It's not gonna do anything for your ankle. What's gonna help your ankle heal is ice, elevation, and ibuprofen. The Norco will make your brain think that you're not in pain, but it really doesn't do anything for the injury. So that's a good thing to know. Opioids work in your brain. They are depressants. They depress our central nervous system, which also regulates our breathing. An opioid overdose is a condition of hypoxia or lack of oxygen to the brain and is not a cardiac situation. And you're going to have to sit through this because it's opioids come in 3 different families: the natural, the semi-synthetic, and the fully synthetic. Out of the natural, you have opium, which comes directly from the poppy flower, morphine and codeine. Those are the only natural ones. Then you have the semi-synthetic: heroin, oxycodone, hydrocodone, that whole family. And then the fully synthetic, which is your fentanyls, methadone, and Demerol. So why is that important? Anything that is fully synthetic can't be made anywhere. To create opium, you have to grow plants in a very dry, very hot climate. Anybody can make fentanyl in their kitchen house from China in 10 days. And I can mix up my own chemical cocktail. Here are some of the opioids. We have methadone, which is a very good treatment for medication-assisted recovery. It covers 24 hours. And then we have fentanyl, which you can see only lasts for 2 to 4 hours, but it is 50 to 100 times more potent than any of the other opioids. And then heroin is somewhere in the middle. And like I said, we are finding fentanyl in everything. I read the medical examiner's reports. And it's difficult to find an ME report where fentanyl isn't present in an overdose death. So we are really no longer in an opioid crisis, we're in an overdose crisis. Like I said earlier, opioids attach to receptors. They cause drowsiness, confusion, nausea. When I've had surgery and they've used opioids post-surgery, I need to be pre-medicated because opioids make me vomit. And they affect the reward system. They make us feel like everything is just a beautiful thing. Dependence and tolerance, you saw that in our video. Anybody who takes medication regularly is dependent on them. I'm dependent on my thyroid medicine, as I am on my high blood pressure medicine and all the other medication. Sometimes when you're on regular medication, it's because it no longer works. That's because you've developed a tolerance. The same thing happens with people that have substance use disorder. They develop a tolerance, and in order to achieve the same feeling that they originally had, they have to up their intake. Some of the signs that we see that might make you think that there's an issue. Taking medication more frequently. You're told to take a tablet, one tablet every 4 to 6 hours, and you wind up taking 4 tablets every 2 hours. That could be a problem. Using it differently than prescribed, taking a pill and crushing it and snorting it, that could indicate a substance use disorder. Doctor shopping, going to frequent emergency departments with a complaint to get your medicine. We do have the prescription monitoring program here in Illinois now that all prescribers have to access to check someone's prescription history. But hopefully that is engaging doctors and pharmacists in a conversation. Do you have an issue? Is there anything we can help you with? There are lots of factors that come into play with substance use disorder. Genetics is one of them. If you have a family history of substance or alcohol use, you are more likely, like you heard our speaker say, it's generational. Chemical imbalances. People that have major depressive disorder or bipolar disorder are more predisposed to a substance use disorder. Traumatic brain injury. We often see that. And mental health. Our mental health, our trauma, psychological injury is often tied into substance use. So we know our environment, our biology, sometimes it's learned behavior. Exposure to stressful life events. I'm going to read the whole slide. So oftentimes, this is really difficult to diagnose because people come in presenting with multiple different things. What do you work on first? Do you work on the substance use disorder, or do you work on where did that come at all? And that was why I was sober for 30 years before I went into recovery. Because I didn't get to my how, why, what, where, and when. I just got rid of the drug. And what came first, the chicken or the egg? Did a mental health issue come first, or did the substance use create a mental health disorder? We see a lot of increase in psychosis. Something that has just started happening up here in our area the last 2 years at the most is an uptick in methamphetamine. For years, I never dealt with anyone who knew even where to get methamphetamine. Well, it's all over now. And we are then seeing a lot of people presenting in the ERs with meth-induced psychosis, which is very difficult to work with. This is talking about co-occurring disorders. It's a lot of words. I'm not going to read them. I don't want to put anybody to sleep. But we never really see someone presenting with just one thing. Even with mental health, people with major depressive disorder also have anxiety because they all interlock and fit together. And the way we have found that people with co-occurring disorders are best served is by wraparound, comprehensive, continuous care. My favorite. And let me tell you, I would find his syringes and I would snap them in half and I'd leave them for him to find because I was going to show him. Didn't stop his use. Now, in my trunk, you find shooting kits, you find smoking kits, you find several gauges of syringes, and a lot of other material that people who use substances need. Because I learned that we all practice harm reduction. We use sunscreen, we brush our teeth, our cars have airbags. Some of us get vaccinated, we use our seatbelts, it's all harm reduction. What does that look like in substance use? If you take your unused medication to a kiosk and dispose of it, thank you. Practicing harm reduction, having a medication lockbox, fentanyl test strips. I also carry them everywhere I go. If you are taking something that did not come out of a bottle with your name on it from a pharmacy, test it. I won't take a Tylenol from a friend if I didn't buy the bottle. It's just how it is. Or I'll test it. Safe injection supplies stop the spread of communicable disease. You can look at any study out there, and syringe exchange started in San Francisco in 1982. And what they saw was their HIV and infectious hepatitis rates drop. Why is that? Because people aren't sharing equipment. And Sharps containers, let's get the syringes off the street. We have an 18-gallon Sharps container on our mobile outreach truck. We take that, we search the street, get them off the street. And of course, naloxone. And harm reduction covers the whole spectrum, from abstinence to chaotic use, and everything in between. When I am working with people who use substances, I try to teach them how to do so safer. Because in my mind, I always go back to my core belief. And my core belief is recovery takes a heartbeat. So if I gotta drive you down to the west side and sit in my car while you pick up, I'll do that. Because I know that person's gonna get it. Whatever way. I know that I'm not a substance user, so I'm not going to get in a car accident. I'm not going to be in put them in a dangerous situation. I'm safe. So yeah, I will do that. I will sit with people while they use their substance. 10 years ago, I would have told myself, what is wrong with you? Bottom line, heartbeat. This is what the fentanyl test strips look like. 1 red line is positive for fentanyl, 2 is not. It's very simple. It is actually a urine dipstick that we can also use to test drugs. The Cook County Department of Public Health is here at the table. They are giving out test strips, as are we. You can stop by any table and get them. And then our instruction sheet talks about how much water to use, because different substances need different amounts of water. Some overdose risks. Every non-fatal overdose leads you closer to a fatal overdose. And that's again the lazy brain who says, oh, I know this feeling, I know what I'm supposed to do now, I'm supposed to shut up. And that's what happens. Combining anything. When we work with our friends who use substances, we ask them to stick with one. If you're going to be ingesting heroin, don't also do a Xanax, because the combination of them is deadlier. They're both central nervous system suppressants and will cut off breathing. Because there is such a variation in street drugs, the people who make them and sell them are not chemists, so the measurements are not exact. Always stick with the same person if you can. Always purchase from the same person, because purity, content varies. Anytime there is any period of abstinence, we find people overdosing and dying often after they come out of jail, after they come out of rehab. Any period of abstinence leads to the potential of a fatal overdose. And most people have to go through at least 4 treatment cycles and 9 years of actively seeking sobriety in order to get into recovery. But, and every person who's talked here today talks about not one size fits all. I did not go to any treatment facility. I received no treatment. Therapy. That was my get out of substance jail free card. We ask people to not use alone. There is a phone number out there called Never Use Alone that people can call when they're going to use. And if the person on the other end can't get a response out of you, they send the MS. Any kind of poor physical health. You can use the same amount of drugs today that you use tomorrow. Not overdose today, but overdose tomorrow. Why? You're dehydrated. That will contribute to an overdose. Using new dealers and new product, also a dangerous thing. When you switch from one thing to another, when you're no longer snorting or smoking and you inject, that boosts your risk of overdose. And it's not just those who illegally use opioids or substances that need naloxone. When I was working in the ER, my oldest overdose patient was an 82-year-old woman who kept waking up in pain, thinking that much more time had gone by than really had, and took another pill from her nightstand. And I talked about tolerance already. So what does opioid intoxication look like? Pinpoint pupils, and I mean really tiny pupils, in whatever light. Now, you know, pupils get bigger when you're in a dark room and smaller when you're in a bright room. Someone who is using opioids will have pinpoint pupils no matter how dark it is. There'll be slurred speech, they pick, opioids tend to make you itchy. So what's the difference between that and an overdose? You still have your pinpoint pupils, but breathing is very shallow, very slow, or it's agonal breathing. What does that mean? One of the moms that comes to our grief group says that she was sitting on the couch and she heard her son down the hallway snoring. And she was so glad that he was getting good sleep. What she didn't know is that he was dying. And it was like sounds like snoring, but it's your brain trying to get as much oxygen as it can. That's why we talk about that. People need to know what that sounds like. Slow, erratic, or no heartbeat. Cold and clammy skin, cold sweat, cold to the touch. And pale, blue, or ashy lips, nail beds, or overall skin color. Our friends that have darker skin get I don't even know how to describe it, but you'd know it if you saw it. It's just ashen. It's, it's just ashy. Us lighter skinned people, lips get blue, fingernails get blue. If you cannot arouse someone, I'll go to the next one, I'm getting ahead of myself. It's the only way someone survives an overdose is with naloxone. It is an opioid antagonist. What it does is it goes to these opioid receptors in the brain, it knocks the opioid off and covers it. That's all it does. If opioids aren't on board, if the person had a fatal heart attack, naloxone will not hurt them. All it does is knock the opioid off of the receptor. The only downside is it only works for 30 to 60 minutes and then it dissipates and disappears. So you do see people re-overdose. It's only effective on opioids. So if you come upon someone and you use naloxone and there's no response, maybe it wasn't opioids, maybe it's something else. Maybe they were down too long. Maybe they had a huge cocktail of other substances that are working differently on the body. It will have no effect on a human being unless they were overdosing from opioids. So it is very safe to use. We teach people the SCARE ME acronym. If you come upon someone that's unresponsive, hello, no response. Take your knuckles and rub them on their sternum. That causes pain. Even people in coma respond to pain. If they respond to the pain and start waking up and breathing cool. If they don't respond to pain, check the airway. Well, you're going to call 911 first, right off the bat. Someone's down, I have Narcan, I'm going to administer it. Stimulate them, they don't respond. Rescue breathing. After you check their mouth to be sure that there's nothing in there, give 2 breaths. If it's a stranger and you're out on the street and you're like, I'm not putting my mouth on that person, throw your t-shirt over their face and breathe through that. Or get a shield. I carry a mouth-to-mouth shield that cost me 65 cents. If after those 2 breaths, there is no response, then you want to get your Narcan and you want to administer it. Narcan, naloxone comes in 3 different forms. A vial and syringe, which is an intramuscular injection. The nasal, which is called Narcan. And then there is an auto-injector that is like an EpiPen and talks to you, but they're not making that anymore. So that is going to start disappearing. These are the steps again: sternal rub, call 911, roll them on their back, check for anything in their mouth, 2 rescue breaths. Can you do that by tipping the chin up? And be sure you pinch the nose, because the air will just go right out the nose. Continue this pattern until EMS gets there. 2 breaths, no response, Narcan. 2 breaths, no response, Narcan. If you run out of your Narcan, just keep breathing for them. naloxone, it's the strangest thing. It's like a Lazarus drug. Someone is laying there, they are not responding, they are blue, they are not breathing. You give Narcan and it's like, it's the strangest thing I have ever seen. Sometimes it takes more doses because of the fentanyl that's on board. Use whatever you have, it's not going to hurt them. People do not come out of overdose fighting. That is one of the myths and rumors that is spread. Doesn't happen, and you know why? Because naloxone puts people in precipitated withdrawal. They are sick. They're not going to fight you. What does sometimes happen is projectile vomiting. So step to the side. I have seen that. Continue naloxone and breathing until EMS arrives. If they do start breathing normally, you want to put them in the rescue position on their left side. And why is that? You don't want people to vomit and then aspirate. So put them on their left side until EMS arrives. Support is needed, and try to get them to stay with you. Tell them they'll start to feel better once the naloxone starts to wear off. Try to find out if there was anything else they took, so that when EMS arrives, you can say, you know what, they also told me they took 5 Xanax. Gives them a better idea of how to approach the person once they get them to the ER. Again, we go through this multiple different ways. Check for breathing, call 911, painful stimulus. If they don't respond, breathe for them, administer your naloxone, breathe for them again, back and forth. In completing naloxone administration records, what does that mean? That's a phone call or an email to one of us, to Daryl, to me, to our organization. And why is that important? We report these numbers back to the state. And if we aren't reporting that it's being used, we're not going to continue to get it. So we need to let people, this is how much naloxone I gave out this month, this is how many reported reversals, and we want to get you more. If you use it out there, we want to be sure to get you additional. Very important fact about naloxone, it has to be kept within a certain temperature. Now you don't have to take the temperature of the naloxone, just don't leave it in your car because heat and direct sunlight breaks it down. The other thing I want to share with you, Illinois Department of Public Health about 6 months ago issued an official statement. If kept in these proper temperatures, naloxone will last 30 years post-expiration date. So if it expires, you do not need to throw it out. The police departments, because they can't use anything that's expired, they donate it to organizations like ours because we can use it for families. Just don't keep it in your car. Keep it in your purse, in your briefcase, but don't keep it in your car. It will outlive you, most of you. That is it. Our phone number. Are there any questions that I didn't cover? He does.
So, you're administering the naloxone of the Narcan, more than twice in one event, or can you, let's say for some reason, the first responders are maybe getting there, you just keep giving them the naloxone, so you might use 3 of them?
Yeah, keep giving it. We work with a lot of police departments, and with the fentanyl that we're seeing in everything, the police departments are reporting that they've used 4, 5, 6, 7 doses to revive someone. In the ER, we used to put people on naloxone drips, as an IV, because people would keep re-overdosing once it dissipated. You're not gonna hurt them. You could give them 1,000 doses of naloxone and it will not hurt them. I see someone else have a question. I do have Narcan here. I hope everybody would like some of it. I need to keep a very brief form just with initials that I went over and you understand everything. It is a confidential form that goes into our database. It doesn't go anywhere else. So if you would like some, I'll sit here at the end of the table and hand it out. If there's no other questions, I thank you for listening to me.
Thank you, Laura. Real quick, we're gonna move along. Got two more little segments we're gonna do. The panel, and one of the, what's very important to me is I want to bring up something that's really, there's a stigma attached to it, but we don't talk about it a lot either. And that's the formerly incarcerated. You know, because we have a tendency to think that that population is just here, and they're lost, and they're this, and they're all these labels are put there. And that's not true. Are there some folks who continue to relish in criminal activity? Absolutely. It is what it is. But there's many folks who come upon that adversity and make mistakes. And I don't think anyone in this room is above making a mistake in life. The deal here, though, is that we have people who, and I'm one of them, who've been down that path, and it does not define who they are. So Sydney and I, as we heard in a minute, we would go into the work for an organization that we went into King County Jail, and we met some unbelievable folks. And one of the individuals that we both agree on, we met right off from the first day, and I'm connected with this cat like he was a long lost brother of mine. And I mean, it's real, it's a true friendship, a true brotherhood. So he's here today. I'm not gonna share anything about his story, let him tell it. But he's here today to shed some light and pull the mask off Rick with me. Rick Swank.
Rick Swain. I just want to start off by saying I'm not the greatest speaker or nothing, but I'm just going to, keep it honest and just speak from the heart. First and foremost, I want to thank God for allowing me to be here today, and I'm thankful for this guy right here. This is my brother Daryl. Like he said, we connected, man, from the beginning. Him, Sydney, man, they've been such a strong inspiration to me because they notice me for who I am. They see me, who I really am. I've been judged and labeled as a career criminal because I've been incarcerated back in the 90s. I got incarcerated 3 times. So, I had that label on me. And to this day, some people still consider me as a career criminal. But as of today, man, God has been so good to me. I have such a strong support system, a strong supporting cast, my family, girl, Sydney, wife. I'm really thankful to actually be here to share my story and just let people know that people do make mistakes in life, but they really want to change and do better, it can be accomplished. I'm living proof of that. Right now, I have my own business. I'm a small business owner. I'm a licensed barber. Right now, my business is thriving. Right now, a lot of doors are opening for me. I have a lot of people who support me. My business is located out in Aurora. I deal with the mayor out there, the sheriff out in Kane County. A lot of people are really, standing side by side with me on my journey to become a better person. I'm so thankful that Daryl has me here today. It's just an inspiration because I know me and him, we've been on a similar journey. I've come from the streets of Chicago. I was raised as a younger guy, growing up around drugs, being engaged in, that lifestyle, caused me to go to prison on several different occasions because of substance abuse and drugs. Today, now that I'm so determined just to be a better person, and I want to just continue to stay engaged with positive people who want to help me so I can, be a voice for other men who want to do better, that's been incarcerated, that's been in the system, because it is good men out here who, want to do better, but really don't have the opportunities or the right type of support system. I'm so thankful for Daryl. Oh man, he's such an inspiration and a strong motivation for me that I value his friendship and I value everything he's doing because he's living proof that it can be done, and I want to follow his footsteps and also show that try not to label people that's made mistakes in the past, who's been in prison, because it is some, and it's actually a lot of good men who really want to do better and will do better, and I plan on being a living proof, a living example of somebody who's going to be successful and who's gonna try to just lead by example. So with that being said, I don't want to take up too much time. I just want to really thank you all for hearing me, and just please acknowledge that there are good men who has made mistakes in the past but can get it together, can really get it together, and just thank you for hearing me out.
I also want to acknowledge Rick's beautiful wife and his mother are here. So let's this thing again is about reducing the stigma and increasing the knowledge surrounding those things that can hinder us at times. So we have a panel, the basic panel. We're going to bring up our KYC clinician and Sydney, and they're going to share some things, and we're going to open it up for questions and answers, and then we're going to go out here to the man and the resource, and you guys can be on your way. How about that? Is that cool?
You go ahead, you do the thing.
Okay, we're gonna have our panelists. Excuse me, folks. We're gonna have our panelists. We have our KY. We have Danielle Kosnovich, who is the supervisor of substance use prevention and recovery services. We have Laura Angel, who is the manager of adult outpatient services. We have Natalie Kulipan. Pronounce that right? Yeah. Good stuff. She's an adult therapist and medical case manager. And we also have Sydney. How do I put this? Sydney is I'm gonna tell you, one of the things I noticed about this young lady, she has obtained her master's in clinical psychology. She's now going for her doctorate in that arena. But for her to be the young individual that she has such compassion to be a part of this solution. I had never seen that before from an individual. And so we had developed a brother-sister relationship. She used to get on my nerve because I tell you, the second time we met, she was coming into and she's all dolled up in this outfit, and I said, you cannot wear that in there. She said, what do you mean? I can't. I said, you're going into a jail with men who don't see women. And you're gonna no. So she had a sweatshirt and she covered herself up. She was ticked at me for a little while. And then that just kicked off our relationship. So, you know, it's that big brother, little sister type banter that we have because I get on her nerve and she gets on my nerve. But at the end of the day, we work so well together because we are committed to being a part of the solution. So I'm grateful for her presence and as well as the rest of the panel. So they're going to share who they are and what they do, and you guys are open after that for questions, and they will respond. All right, there you go.
So I'm going to start, like Daryl said, I'm Danielle Kasanovich. I am the supervisor of Super Services, that is Substance Use Prevention and Recovery Services. So when a client comes in, they get a substance use assessment if they request it or if a therapist discusses the need for an assessment with them. At KYC, we provide the assessment and we determine the proper need or level of treatment that is required. Here at KYC, we provide intensive outpatient treatment and outpatient treatment as well. We have an adult program and an adolescent program. Currently, our adolescent program is on a standby for taking new clients, but as soon as we get a staff, we are going to be up and running with that as well. What else? Our program stands out from others because we work really hard to empower our clients to advocate for themselves, build their self-esteem, and work collaboratively with other agencies locally. We work as well with other agencies. One of our favorite is Live for Lally. Thank you for the free rides. Thank you for the sibling groups. We rely on the different agencies as an outside support that is really great for our clients. I think we're going to go person by person, but any questions regarding the substance use services that we provide here. Okay, great.
I'll give everybody another chance at the end once we're all done here. Hi, just to reintroduce myself, my name is Laura Angel. I'm the manager of adult outpatient services here at Kenneth Young. And so our adult outpatient therapy, along with our psychiatric services. So as you can imagine, we end up coordinating with Danielle and her team quite a bit. We have a lot of different shared clients. I wanted to thank Daryl for inviting us to participate in this event and help us to collaborate more closely with our community-based division. As we all know, and as some people have already spoken to today, addiction does not exist in a vacuum. There are individual, community, and systemic factors that can influence the likelihood that an addiction and/or a mental health condition will develop. We need to intervene on every level possible in order to tackle this problem. Our work, though, on this team, intervening on the individual level, can look like a whole bunch of different things. It would be really hard for me to list like every single thing that a person should need therapy for. Sometimes we're providing very practical, skills-focused therapy. Sometimes we're helping a client to sort of retrain their brain. And a couple of people have already spoken to that, the way that substances affect our brain, not only the initial use, but also how that keeps that behavior going. So sometimes we're teaching clients skills to catch and sort of work with the thoughts, feelings, and sensations that reinforce the addictive part of the mind. Other times we're working to heal wounded relationships between family members, or sometimes we're even counseling those family members, whether or not they maintain a relationship with their loved ones who have a substance use problem. We help individuals to heal old wounds, whatever that means for them. And then sometimes we're also working with clients to explore their values, to figure out what their values are, to examine the way in which the life they're leading is or is out of accordance with those values, and to work toward that, so that they can have a life that is more meaningful and more fulfilling without addiction than with it. So that, in essence, I would say is some of the goals of therapy and some of the things that we on the adult outpatient team are trying to help people to work towards, whatever it looks like for them. I'm going to pass it along to Natalie, who is also on my same team, but she has a breadth of experience also from our recovery side and has some other insights to offer.
Yeah. Hi, everyone. Good to see you all here. I know it's Saturday. The sun is shining. It's beautiful. So I really appreciate the fact that you're here with us at Kenneth Young. So I'm a supervisor of medical case management. Our team specifically kind of is on the maintenance end of things, meaning that clients are usually doing their own thing, and if maybe something comes up, then they turn to us. We also have a recovery and PSR team that kind of helps clients develop a routine if maybe some more mental health concerns have come up and they've, kind of just are not seeing their life play out the way that they want to. So we offer groups that help with social skills. There's a co-occurring disorders group, so they all kind of go hand in hand. And something over my time as a clinician, I've realized that, substance use, while stemming from many reasons, sometimes it's just a coping mechanism. It's a way to have something that's going wrong with your life and feeling like that substance can maybe fill that void. And unfortunately, over time, it may, develop into an addiction. And as well as, I think on the clinical end, we still see a lot of stigma of addiction being a personal choice. Like people have mentioned before, as if somebody wakes up in the morning and hope to devote all of their time and energy and investment into this. And so sometimes therapy, it's a way of meeting individuals where they're at. It's figuring out what should take focus. You know, sometimes it is the symptoms, sometimes it's the addiction, and sometimes it's the underlying issues like trauma or things that may have happened that has pushed them into this path that they don't want to be on. And so we work and take a collaborative effort and change coping mechanism. Reduction, it may be on the table, but it's not something that is the first option. And maybe there's other things that are a better choice or more fitting in the situation. And I think harm reduction also helps in the clinical sense with dealing with really overwhelming emotions that come with addiction, like shame and guilt, and feeling like maybe so much bad things have happened in your life that now maybe there's no way out. And so it's just really about working with all of the facets, and it's kind of like it's like juggling. You're handling a lot of balls up in the air and figuring out if you drop one, which will break and which one will bounce, and you can pick it right back up. And so yeah, I'm gonna pass it on to you.
All right. You guys hear me? Never really talked into a microphone before. So I'm Sydney.
You guys can all plug your microphones, that would be great.
What?
Move them closer,
Move
Jake.
it closer.
Yeah.
How's that? It's really loud. Okay. So I would say I've been both blessed and cursed to have the opportunity to work alongside Daryl for the last 2 years. Because when he said that we get on each other's nerves, that was really the understatement of the year. But yeah, him and I, it was actually funny. So about 2 years ago, we started working together in the Kane County Jail, working with men and women detainees who struggle with substance use issues. And we found out months later, we had actually crossed paths years before in the Cook County Jail, doing similar work. So that was funny. But Daryl's been such a mentor to me. He's helped me see the issue of addiction, not just from such a clinical reference point, and really see it more as a holistic issue, and seeing these individuals and helping them rediscover their purpose in life, their worth, because a lot of that is lost, unfortunately. So I don't have a ton more to add, and I've been working with the incarcerated population for about 5 years now. Like Daryl said, I think it's one of the most stigmatized groups of people there are. And Rick, who was just speaking, is a past client of Daryl and I's, and just from seeing him when we first met him as someone who was facing the possibility of going to prison for the rest of his life, and now seeing him here today. And just a totally new way of living. It's just the most amazing thing ever. So happy to answer any questions about working with that population and anything like that. Happy to be here.
So this time we'll answer questions.
How can the community help you help others? How can we get involved?
I think one of the very valuable ways of contributing is showing up to events like this that are intended to raise awareness and help to reduce the stigma around seeking treatment. That's one thing that comes to mind for me, is just showing up and educating ourselves.
I know there's volunteer opportunities here at KYC that definitely is great for anyone to volunteer at KYC.
Yeah, I would also say push yourself outside your comfort zone and expose yourself to people that you typically wouldn't be around, and learn about how they got to that point in their life. Why? Because working with addictions, every single one of these people has a story, and a lot of it is really traumatic. And they're really no different than you and I. So I would say just trying to get in touch with people that you normally wouldn't.
Yeah. We do have 2 fundraising events that last year I had the whole IOP was able to go and participated together. I know that any community involvement is great, so we try to get clients to participate as much as possible. That's always appreciated. Anything else?
So I'm just wondering, it seems like there's a continuum of care here, and I just wonder, people who come to you, like typically, how do they show up? Those of their addiction, have they come out of rehab? How do you personally know them?
So we see them in all different stages. Sometimes they'll come from inpatient, sometimes they'll come from a referral from the police department, right, first day being sober. From the hospital, we get them in different stages. Sometimes we'll see people and they'll want an assessment, but they'll be 5 years sober, but they still just want to be assessed at that time and need that additional support with maintaining their sobriety. So we're open to whatever stage people are.
I'm just wondering, because resources are in such high demand, is there a long wait time for people to get into the services?
We've always been very blessed on the super team. We've been able to take them very quickly to an assigned therapist.
I can speak to on the mental health side, there is a little bit of a wait list, but I think one of the wonderful things about having our two teams working in coordination is that we can provide, for example, on the substance use end, a slightly higher level of intensity of services in the beginning, and that usually allows us some more time so that the person is still connected with a clinician, is still being assessed and being treated while they wait to be connected to their therapist who's going to provide that more long-term sort of support to deal with some underlying issues.
What do you find is your go-to, really, I don't want to use the word difficult, but where you're having to be a little bit more intentional, let's say, in your efforts? What's your go-to? Because we can cross those a lot.
By intentional, do you mean directive with the client?
Yes, how do you get past that? What's the process that you use to connect with that client?
I think for myself, it's exploring with the client what they really want. There's no cookie cutter approach. Everyone wants a different idea of recovery. So then we have to design recovery from their point of view. If their recovery is getting clean for a week, okay, that's a really good starting point for them. Let's work towards a week. Even if that's their future goal forever, a week is better than nothing. Okay, then
Which is perfect.
yes.
Meeting them where they're at, in other words.
Yes.
Yes.
So, even if it's, I want to just get hooked up to services, even if I don't want to work towards getting clean, that your goal is getting hooked up at services, that is a great goal because you're hooked up with services. It's meeting the client where they are, getting them linked to mental health services.
And for me, I think sometimes the experiences can be a bit different because I might have clients, for example, who don't see their current substance use as a problem, or maybe it isn't impacting some areas of their life, and so it's not currently something that they are trying to work on. Instead, we're more focusing on what else is going on in that person's life and in their mental health. In general, I tend to take a person-centered approach to therapy, and so of the utmost importance in that therapy is the therapeutic relationship, maintaining empathy and positive regard for my clients. And then also, not to get too clinical, but there are some approaches that we use in like motivational interviewing, for example, to help draw discrepancy between where a person is at, where they would like to be, and how some of the things that they're currently engaging in may be acting as a barrier to those ultimate goals. But the goals always, of course, have to be based in the client's own values and what they want, and not so much me deciding what I think that person should want. That's just me personally.
Yeah, definitely. Number one thing I think is, where's that person at? What are they looking for? What do they want? And then after that, I like to picture like our toolbox. You know, I think we all have seen one, maybe in the garage, it's got a bunch of things in it, half the time we don't know what's in there. And for me, it's important to open that up, put it on the table, figuring out what's a good fit, what's not, and continue working and making sure that it's fit to the client's needs. And to move forward, or sometimes honestly just hold space to stay in place. I think stability is somewhat seen as boring, it's flat, nothing's happening, but that is the part where I think the magic happens in recovery, where stability is what we're looking for. We're looking for that kind of straight and narrow where it's not chaotic, but like a roller coaster.
Me? What? Your question was about dealing with like what, resistant clients?
Yeah, well, for you, it would be, you know, it's a no here because you also have deal in detail with DUI clients.
Yeah.
You know, you're very immersed in that.
Yeah, so my clients are either in jail, which is not the ideal place to get sober and start your recovery journey, or they're court mandated to come to treatment. None of them want to be there, they have to be there, or they go to jail. So my approach is, I don't know, I think the biggest thing is like, do not let them feel like they're ever judged, because that's been their whole life, is being judged and having had a label put on them. So I think that's my biggest thing, is just make them know that like you and I are on an even playing field. I'm no better than you, you're no better than me, we're just trying to work this out together and see how we can get you to where you need to be.
Do any of the people that you work with have like mental health diagnosis? Like maybe in their 30s they find out that they have bipolar or they have PTSD. Like how often do late diagnoses show up for people with 30s and 40s?
I think when substance use is brought into that, it complicates things, because kind of like what she was saying earlier, like what comes first, the chicken or the egg? Was it the substance use that drove this person into more, other mental health issues, or has all this time they've had this issue, but it's been masked by substance use and it's never really fully come out? A lot of the people we see, especially incarcerated, they've never had any mental health treatment before, so there would be no time for them to ever get diagnosed until they've seen a clinician while they're in jail. So I don't really have a solid answer for you. I don't know, what do you guys think?
I think that it's a complicated issue, and I think another factor as well, it's less common to be diagnosed with a mental health diagnosis later in life. There have been so many changes in how we view mental health, and more people I think are seeking treatment than ever, and so even some people I work with who are older, maybe in their 50s and 60s, may be getting diagnosed later in life, but they wouldn't have gone into anybody. Their parents wouldn't have brought them to treatment. They wouldn't have talked to a doctor or opened up to anybody to receive a diagnosis to begin with. So I think there are some complicating factors like that, in addition to like you were saying, when it comes to substance use specifically, and what came first.
Any other questions? Thank you folks so much.
Thank you. Thank you.
So you folks can head out and with the van, the resources, snacks over there, water, so thank you so much for coming. Excuse me.